Welcome to our exploration of infectious diseases, Part 2. Let's talk about two important tick-borne illnesses commonly seen in the Northeast and Upper Midwest, including states like Connecticut, Massachusetts, New York, Pennsylvania, Wisconsin, and Minnesota, namely Lyme disease and anaplasmosis. Starting with Lyme disease, the mainstay of treatment is doxycycline. However, if the patient is pregnant or a child, we switch to amoxicillin. For patients with neurologic or cardiac involvement, ceftriaxone is used. Now here's something crucial to remember. Even after successful treatment with doxycycline, a patient may continue to experience malaise and muscle aches for up to 6 weeks. That's completely expected. There's no need for repeat testing or additional treatment during this time. Moving on to anaplasmosis. This disease typically presents with fever, headache, and muscle aches, but notably, there's often no rash, although a maculopapular rash may occasionally be seen. Lab findings are key here. Patients may have low white blood cell counts, low platelets, and elevated liver enzymes. You might even detect moruli inside granulocytes on the smear. Diagnosis can be made by examining a buffy coat or performing a peripheral blood smear, looking for intraleukocytic moruli. Now, here's a pitfall to avoid. Don't rely on serologic tests for Lyme disease in the early stages. They can be falsely negative. Co-infection is common, so if your patient shows lab abnormalities suggestive of anaplasmosis and has a Lyme-like rash, you need to think broadly. Bottom line, start empiric treatment with doxycycline immediately if you suspect anaplasmosis. Now let's turn our attention to tick-borne diseases in the southeast and south-central United States, especially in states like North Carolina, Tennessee, Oklahoma, Arkansas, and Missouri. These are Rocky Mountain spotted fever and ehrlichiosis. Starting with Rocky Mountain spotted fever, this is a medical emergency, and early treatment is critical. Patients often present with fever and headache, followed by a rash that starts at the wrists and ankles and spreads to the palms and soles, eventually becoming petechial. One important distinction here is that unlike secondary syphilis, which also affects palms and soles, Rocky Mountain spotted fever presents with fever. Lab findings typically show thrombocytopenia, hyponatremia, and elevated liver enzymes. But here's the key point. Don't wait for labs. The diagnosis is clinical, and treatment must be started immediately due to the high mortality rate if delayed. And what's the treatment? Doxycycline. Yes, even in pregnant women and children. Now moving to ehrlichiosis. It also presents with fever, malaise, and headache, but typically does not cause a rash. However, a maculopapular rash can sometimes be seen, but if present, there's no central clearing. Lab findings include leukopenia, thrombocytopenia, and elevated liver enzymes similar to anaplasmosis, but in this case, moruli are seen in monocytes instead of granulocytes. Diagnosis can be made with PCR or peripheral smear, but just like with RMSF, empiric doxycycline should be started immediately. And don't forget, Francisella tularensis, the cause of tularemia, is also endemic to these regions, not included in the slide. Neurocystic herpes is a parasitic infection common in certain regions, identifiable by specific MRI or CT findings, such as cysts with scolex, ring-enhancing lesions, and calcifications. Cerebral toxoplasmosis presents with distinct multiple ring-enhancing lesions, a critical diagnostic feature to note. Neurologic symptoms in HIV-positive patients can be because of toxoplasma, CNS lymphoma, and progressive mutifocal leukoencephalopathy. First, toxoplasma causes multiple ring-enhancing lesions, often in the basal ganglia, with CD4 less than 100. Second, is CNS lymphoma causes a single large lesion, with CD4 less than 50, and is EBV-related. Last, PML causes white matter lesions without enhancement or mass effect, with CD4 less than 200, and has a rapidly progressive course. When managing HIV patients, it's crucial to recognize and prevent opportunistic infections based on CD4 cell count thresholds. For pneumocystis jirovecii pneumonia, or PCP, start prophylaxis when the CD4 count drops below 200, or if the patient has oropharyngeal candidiasis or a history of PCP. The preferred agent is TMP-SMX, with alternatives including dapsone, atovaquone, or pentamidine. For Toxoplasma gondii, prophylaxis is indicated when the CD4 count falls below 100 and the patient is IgG positive. Again, TMP-SMX is first line, but alternatives include dapsone plus pyrimethamine plus leucovorin, or atovaquone with or without pyrimethamine and leucovorin. For Histoplasma capsulatum, in patients with a CD4 count under 150 who live in endemic areas, the prophylactic agent is itraconazole. For varicella zoster virus exposure, if an HIV-positive patient has close contact with someone who has chickenpox or shingles, give varicella zig or IVIG within 4 days of exposure. And finally, remember to consider tuberculosis screening and prevention at any CD4 count, regardless of immune status. When someone is exposed to hepatitis A, post-exposure prophylaxis should be given. For healthy adults under 40 years old and children over 12 months, the hepatitis A vaccine is preferred. However, for children under 12 months or those who are immunocompromised, we give immune globulin instead of the vaccine. Let's talk about hepatitis B, starting with acute HBV infection. Most acute cases are self-limited, with over 95% of patients recovering with just supportive care. Antiviral therapy, such as tenofovir or entecavir, is used only in severe cases where the INR is greater than 1.5, or if the patient has a prolonged course, defined as more than 4 weeks of jaundice and bilirubin, over 3 mg/dl. Antivirals are also used if there is acute liver failure requiring transplant. Now moving to chronic hepatitis B, which is defined by the presence of HB-Sag for more than 6 months. There are 2 types. Inactive chronic HBV. These patients are HB-Ag negative, have normal ALT, and HBV DNA less than 2,000 IU/ml, and they do not require treatment. Active chronic HBV. These patients have high HBV DNA, ALT more than twice the upper limit of normal, and are HB-Ag positive, and they should be treated. When managing recurrent herpes labialis, treatment should begin at the onset of symptoms. Now, some patients may benefit from chronic suppressive therapy, including following situations. If the patient has 4 or more episodes per year or experience painful or disfiguring lesions or complicated outcome history like aseptic meningitis. Measles, a highly contagious disease, spreads through airborne droplets. Clinically, measles begins with high fever, cough, and a maculopapular rash that starts on the head and spreads downward. A classic finding is Koplik spots, small white lesions on the buccal mucosa, which are pathognomonic. Diagnosis is confirmed by serum IgM testing or nasal RT-PCR. Management is mainly supportive, along with airborne isolation for at least 4 days after the onset of rash. Finally, complications include pneumonitis, otitis media, and the rare but fatal subacute sclerosing panencephalitis. For malaria prophylaxis, the recommended options are atovaquone proguanil, doxycycline, or mefloquine, depending on the resistance patterns in the region you're visiting. One special point to remember: Plasmodium vivax and Plasmodium ovale have liver-stage hypnozoites, dormant forms that can cause relapses. So, these require an additional medication called primaquine, but make sure to check for G6PD deficiency before giving it. And finally, for pregnant women, the prophylactic drug of choice is mefloquine. Maculopapular rashes on hands and feet can be caused by various infections, including Coxsackie A, rickettsia, and syphilis. Candida in the blood is never a contaminant. It always needs evaluation and treatment. Key risk factors include central venous catheters, TPN, and immunocompromised states like neutropenia. Always perform an ophthalmologic exam, as IV treatment alone isn't enough for endophthalmitis. Treatment involves removing the catheter, even if it was placed after the patient became ill, and starting empiric echinocandin, such as caspofungin. And remember, Catheters must be removed in cases of Staph aureus, Pseudomonas, and Candida, not for coagulase-negative staph like epidermidis. Blastomycosis and histoplasmosis, both found in the Mississippi and Ohio River valleys, including Indiana. Blastomycosis can cause cutaneous plaques and ulcerations, bone lesions with sinus tracts, and though rare, it can involve the central nervous system. Histoplasmosis, on the other hand, typically presents with hilar or mediastinal lymphadenopathy, hepatosplenomegaly, pancytopenia, and even adrenal insufficiency. If you see an asymptomatic small lung nodule on imaging in an endemic area and histoplasmosis is suspected, there's no need to treat. When you see a patient with flu-like symptoms and a rash, especially erythema nodosum, and there's a history of travel to the southwestern U.S., think coccidioidomycosis, also known as valley fever. It's endemic to southern Arizona, California, New Mexico, and Texas. Symptoms typically start with a rash, followed by pulmonary symptoms within 1 to 3 weeks. If there's eosinophilia in the CSF, that's highly suggestive of fungal meningitis, particularly coccidioides. Treatment involves fluconazole and amphotericin. Aspergillus infections classically presents with halo sign, which is nodules with ground glass appearance in immunocompromised patients, require specific antifungal treatments, with voriconazole being a key option. Sporotrichosis is caused by the dimorphic fungus Sporothrix skenki, commonly known as rose gardener's disease, because it's often acquired from handling soil, plants, or thorns. The most common form is cutaneous or lymphocutaneous sporotrichosis. It begins as a painless papule, which progresses to an ulcer, and then forms nodules along lymphatic channels. This pattern is called sporotrichoid spread. In immunocompromised patients, the infection can become pulmonary or disseminated. Diagnosis is made by culturing the lesion, and a biopsy typically shows cigar-shaped yeast. Fusarium infections, particularly in immunocompromised individuals, present with skin nodules and require aggressive antifungal treatment. Acute schistosomiasis, or Katayama fever, is linked to freshwater exposure with fever, urticaria, angioedema, and eosinophilia 2 to 4 weeks later. OVA/serology often negative early. Steroids used in acute phase and praziquantel in chronic sequel. Enterobius vermicularis, or pinworm, causes nocturnal itching. Scotch tape test is used. Albendazole or mebendazole given and repeat in 2 weeks. Treat all household members to prevent reinfection. Strongyloids stercoralis is a parasitic infection that often begins with a local skin reaction, followed by a pulmonary phase, causing cough and wheezing, along with eosinophilia. As the infection progresses, patients may develop gastrointestinal pain that feels ulcer-like. One of the biggest dangers is hyperinfection syndrome, which can occur if the patient is given steroids, leading to severe diarrhea and sepsis. Treatment includes both ivermectin and albendazole. And here's a critical point. If you suspect strongyloids, do not give steroids until after serologic testing is done, as it could trigger life-threatening hyperinfection. Thank you for joining this journey through infectious diseases. Stay informed and proactive in managing these conditions.